LSI 2021 at the beautiful Ritz-Carlton Laguna Niguel. It's nearly true tales of innovation. I'm your host, Benjamin Glenn. My guest is Daniel Hawkins. You've got a new company here. Maybe there's some folks you're advising. Tell us more about what brought you out to the summit this year.
So one is just fundamentally the interactions. You can't beat an LSI kind of an environment. You have startups here. I'm advising a few that are here. You have strategics. You've got funding sources. We don't particularly need funding for my current company, Avail, but there are funding sources here, and it's great to just reconnect with everybody. Really, what we're doing at Avail is a form of telemedicine in an operating room, and it's taking a bit to educate the community as to what we're doing because we've been apart for so long. Ironically, using remote technologies and video, which is what Avail's doing, but it's harder to disseminate that information and create that ecosystem understanding. So that's really the reason why I'm here today.
Oh, that's great, Daniel. So it's interesting you talk about telemedicine and the work that you're doing at Avail, but this is not you're on the phone with the advice nurse or you just called your doctor. Tell me more about what's the information that you're learning how to exchange remotely now.
So it's more actually about telepresence is the way I'd encourage you to think about it. I started the company in 2017 after 23 years at that point in the medical device business. My last company was Shockwave Medical, and you keep on going back successive companies into history. It's all been devices. And my very first device-based experience was pre-pulmo shot stent with ACS. So this is Eli Lilly's angioplasty division. It's now Abbott Vascular by way of Guidant. And the very first business trip I took was a road show in the city of Chicago, it turned out. And I was so excited to see a bunch of procedures and visit multiple physicians. And then the day happened. You drive, you're in traffic, you're late, you go to a meeting, you go to a procedure, you're waiting for the next one. At the end of the day, we were supposed to see 6 to 8 procedures in a day. We saw 3. We were supposed to meet with 4 physicians. We saw 2. And I left that experience unmoved, right? It was not quite what I was hoping it would be. What I realized, there was a bunch of inefficiencies. Fast forward through my career and every clinical stop I had, from Intuitive Surgical to all the other companies I was involved with, to when I started Shockwave and was running them, that inefficiency, I should say, propagated all through. The kind of telemedicine Avail's doing actually enables folks, clinical staff, sales staff, even corporate, to be in the procedure room, actively participating with video feeds, telestration, and the like, and provide all of that clinical support in a procedure room without actually being there. So now we're changing the efficiency of what's happening. It's less about data flow and more about the interaction that needs to happen for clinical support, new product introductions, and new technique introductions with the efficiency that you don't otherwise have. It's little understood, but about 50 to 60% of the average field person's time is spent in logistics around procedures. So very highly skilled, highly compensated, incredibly necessary staff is not there half the time because they're driving to a case, waiting for a case, they're stuck in one hospital but needed somewhere else, those logistics. So we're building a network of these hardware systems, telemedicine hardware systems, that you can access remotely so that you'd be able to increase the ability to support customers.
It's very interesting, Daniel, listening to you sort of play back the tape from your own career. And it's your own unmet clinical need. My clinical need of actually being there. And now here you are. So isn't that amazing now with, and it's astonishing no matter how advanced, like the intuitive system, extraordinarily. Da Vinci is an amazing piece of equipment, right?
Yeah.
No matter how amazing that is, it's not going to help you make all the lights and
Exactly.
get through the hospital, get scrubbed in. So it really is interesting. You're kind of getting that last mile of inefficiency. It's very interesting.
Exactly. And my personal experience at Shockwave was particularly enlightening for me. I was the inventor of the technology.
Mm-hmm.
And between myself and one of my co-founders, we were present in absolutely every one of the first 42 cases. So if you think about that for a second and understand that those were done in New Zealand, in Austria, and in Germany, we both live in California. So how does that going to work? There was a year I traveled 250,000 miles for that company.
Wow.
My most difficult trip was flying to New Zealand, landing, quickly changing, running to the operating room. We did 3 cases, had dinner, and I flew home.
Oh my gosh.
And you ask yourself, how efficient is that, right? Not terribly. And in that kind of an environment, obviously that's an extreme. But when we started building our sales force, we started with 6, 8, then 12, then 15. You can't cover the country in peripheral vascular with 15 salespeople. Mm-mm. It's not possible. The large manufacturers have 100 to 150 each. You can't get there. So we were finding that we're flying people all over the place. 1, it's expensive. 2, it's horribly inefficient. Mm-hmm. And if you're trying to enroll a clinical study, you're trying to, in that example, we were trying to catch those patients that happen in the procedure flow. You don't schedule them necessarily. They happen in the procedure flow. That's challenging. You try to group them, but it's difficult, which means that if you can't physically be there to enroll, and that's a requirement per your protocol, you're missing cases all the time. So your clinical trial gets longer. But if you have a way to, it's a huge expense, and you're running the company trying to get a trial done because you can't physically be there when the patient happens to be there. Our system, Avail system, would allow that problem to go away.
So the Avail, does that, is it almost like you can have that informed consent conversation can happen with the right people at the right time?
It could be, but really we're intended to be right next to the procedure table. So it's a tower, if you will. It has a couple of high-resolution cameras on it and a large screen. It's connected via Ethernet to the cloud. We can do Wi-Fi. We don't love it because we don't think it has quite the image quality that is necessary for procedural dynamics. Very importantly, on the opposite end of that, we have this portal that somebody remote, be it a salesperson, clinical specialist, clinical trial team, if you will, medical education group, proctors, they show their availability on a schedule, on a calendar that they manage for their user account. That bounces up to the cloud and down to all of the units in the network, all across the country. So when somebody needs to find a particular person, John Smith from XYZ company, their name will show up on the panel of our unit as being green if they're available, not green if they're not. Tap that, outbound call happens, they're in the case. Within 2 seconds, bing, wow. They're in the case. So if think about a clinical trial for a moment. You have a patient on the table, you realize they've been consented in advance, you realize, perfect case. Let me go get XYZ company. Tap the screen, they're on, available, you enroll that patient, close down, finish the forms, you're done. As opposed to, I missed that patient because I wasn't there and now my trial got longer. And that same dynamic would happen if, I'll use Manhattan as an example, if you happen to be at Columbia and you hear from NYU, I've got an inbound in 45 minutes, can you be here? No,
Not
actually
likely.
You can't. You can't. Anybody who's been to Manhattan and tried to do that
That's
trial,
not gonna happen.
You're not going to be there. But with our system, you can. You finish up at Columbia, finish the case, get to a place that is private, obviously HIPAA-related reasons, and you tap and you're in. And you can do the whole case that way. We have emergency cases being done that way, wow. Neuro cases and stroke, AAA, trauma cases, general surgery procedures, scheduled and unscheduled, happening remotely. We envision a dashboard that you are doing that at home with multiples at the same time. We're working on that technology right now.
Wow, that's fascinating. So it really is Avail. I mean, you really are in
Yes.
both senses of the word. You really are.
Exactly. Avail meaning available, and avail meaning to benefit from.
That's
So that's why I
fantastic.
named the company Avail.
Yeah, that's a great. That's one of the better naming conventions. Like
appreciate
the twofer, right? It's a twofer.
It's a twofer.
Yeah, I like that. So, what's your strike point right now, or if you can talk about it? So, what's your first point of entry? Where are you? Are you prototyping it? Who's
So
involved
we're
right
actually
now?
very much commercial right now. So I started the company in 2017, and we were stealth for really until April or so of 2020. I intended to be stealth until about August of 2020, and the pandemic happened. So we had a billboard website. Click here for more information. After the medical device sales reps and clinicals were shut out of procedure rooms, we were getting between 15 and 25 inbounds every day. Where are you guys? I need access. I'm troubled, etc. I can't get in. I'm trying to run a trial. I need to get my doc, whatever it is. That was happening every day. So we rushed a website. I grew from 20 people, 22 people at the beginning of 2020 to 140 now, largely hired over Zoom. Vast majority, raised about 115 million in between those two time periods.
Congratulations.
And the company has we've just been growing like a weed.
Wow. And so these are units in hospitals?
Yes.
Like in OR? So how many units per hospital? What's your average
So
penetration there?
the way our system works is we actually keep those units on our balance sheet. We don't charge the hospital for the units at all. So that's an interesting part of this dynamic. We place the units, and then we charge for access. Kind of think of it as, I'm going to give you the cell phone. I need a monthly plan from you, and depending on the length of your phone call, I'll send you a bill. That's how our system works, right? So
They're responding well to that?
They're responding well to it. Yes, I mean it's free to hospitals, so that's a good price.
So they'd rather have no capital costs, but they can have the operating costs. They can absorb that easier.
Yes.
Is that kind of the?
So hospitals can speak to hospitals using our system, right? And we have networks of hospitals like small IDNs and mid-sized IDNs that are doing that. Facility 1 is helping out a colleague in Facility 5, and they're doing it back and forth through the Avail platform. We also have industry that is supporting procedures in operating rooms, and then proctors on behalf of industry training new techniques and technologies through our system. So in terms of entry point, we're building a two-sided network.
Very
right?
interesting.
So we've got, at this point, about 3 dozen manufacturers, vendors on one side, and probably 400 plus hospitals that we have had interactions with, and a couple hundred of those we're in contract with. So really, really nice kind of an ecosystem that's being built.
Can you talk about what is a proctor? What is the proctor's role here?
So a proctor in separate from Avail, the proctor model has existed really since the beginning of medical devices, the beginning of medical education. A very experienced surgeon will be shoulder to shoulder with a less experienced surgeon, right, to be able to walk through a technique or a technology. With all the medical legal issues right now, the experienced surgeon can't touch the patient. So they're basically just standing there in scrubs, kind of hands to the side, walking through, look at this, do that, that sort of thing. And it's an advisory role on a new technology. Okay. Because of that dynamic where they can't actually touch the patient, it lends itself to telemedicine beautifully. From that perspective, right? Because you're not missing anything in that way.
Right.
The other reason why it's really important is because the proctor, if you think about it for a second, let's say your proctor is an attending at the Cleveland Clinic, let's say, and you need to go to pick a state, Alabama, to be able to proctor a physician there. That means the physician at the Cleveland Clinic needs to leave their practice, reschedule all their patients, fly, take an overnight, possibly 2 overnights, run a series of cases, fly back. So they've missed a couple of days in their clinic. They've had to reschedule procedures, all for what? To be able to train somebody, and they get nominal compensation from industry for that. Mm-hmm. But really, what they're trying to do is advance the clinical medicine engine, if you will, kind of push technique out there. It's for the greater kind of clinical benefit.
Sure.
But that's how new technologies get introduced. complicated technologies like transcatheter aortic valves or new aneurysm devices or what have you is via proctors. We're creating a network of proctors to be able to make that available, but do so remotely where they'd be able to have 2 or 3 cases, some office time, a proctoring event, go back to their office time in some cases, all in the same day.
And Avail makes that happen.
And Avail makes that happen.
That's fascinating. Thanks so much for sharing that with us.
Yeah, absolutely.